Thank you, and a very good morning to you. I should start with to say my name is Chris, in the best fashion of Kate Granger. Not that she needs any recommendation from me, but Kate, I think, is about to go on a bit of a short tour and starts, I think, in Leicester around June the 17th. So, like Ashley, I'm sure for those of you who haven't seen Kate, you would be inspired by her, both her commitment, but certainly her passion and her compassion, bearing in mind the situation she finds herself in. So, not that she needs a plug from me, but my name is Chris, and I'm here to talk about reducing readmissions through collaborative working. I feel a bit of a fraud, if I was brutally honest, because the only bit of that first slide, or the two bits that are true, is that my name is Chris Wood and I am from Burton Hospital Foundation Trust, because in truth, I'm probably not going to talk about reducing readmissions through collaborative working. And you'll see as we sort of go through the slides and maybe some of the discussion this morning as to why that might be, not least of which it's an enormous subject. And actually, what we'll find is that readmissions on their own are just a consequence of many other things. And those many other things are too vast to cover in the next 20 minutes or so. So the other thing is that it's rather a journey around the country this morning, isn't it? Around the UK, because we've gone from the northwest to the southeast, across to Ireland, and now I'm a very proud West Countryman, so you might get a Devon and Cornish twang to everything I say, irrespective of the fact I've somehow ended up in the middle of England. Goodness knows how that happened. So, in any event, reducing readmissions or the issues that face the health service around the activity and demand, the subject of an enormous body of work. Now, I don't intend to talk about system change and the need for integration at a structural level, as others far more informed than I have already published their findings. I think Simon Stevens has obviously got in before me. But some of what we've already heard from Simon and elsewhere is being transferred into policy and action. So what I want to focus on is really a couple of the enablers, if you like, and a change attitude towards change. So it's back to this, in many respects, about culture and certainly about what's good for patients. So in lots of ways, it's more of a personal perspective on a couple or a few discrete areas which I've personally observed, either as chair at Burton, and that's fairly limited, and it's not been for a great deal of time. So I'm very much a new boy to the health service in lots of ways. But probably more importantly, as a patient myself and as a carer, which is often the best perspective and prism that one can view the health service through, I would strongly suggest. So this will be touched on probably from every speaker. I'm sure it was yesterday. It certainly was from Paul in the previous talk. The 5-year forward view, we're all aware of that, which the document sets out much more than a vision, I would suggest, for the NHS, but an absolute necessity for change. It's undoubtedly a set of principles, aspirations, and intentions that I would suggest few, if any, could argue with. But the pillars of it really are about organisational form. It is about moving the current organisational structures to more integrated structure. And in lots of ways, it doesn't actually depict how one does that, but the basic principle is that we must, and I don't think that could be challenged. Now, one can anticipate that with a government that has a mandate for the next 5 years, much of this plan clearly will become a reality, and there's much to welcome in the contradiction that is stability of change. However, and there is always a however, history does suggest that wholesale change will not happen quickly. And certainly I can talk from a provider perspective that there are significant barriers in the way of reform, not least of which is the fact that the NHS is a very decentralised industry. You may disagree that it is an industry, you may call it an organisation. I believe it's an industry and not a corporate. And I think in there lies some of the issues around pace of change that we're facing now and certainly have faced in the last probably 2 decades. Ashley, put your absorbent suit on. If you take away some of the negativity. It'll change. It'll change. So what's the worry? What are we worried about? Well, as I mentioned before, there's a huge and well-informed body of work around unplanned admissions. Not readmissions, they're just a feature of admissions in a sense. So unplanned admissions, leading to ever-increasing demand on health systems, not just here in the UK, in England, but around the world. Now, it's interesting on reflection, the lack of foresight in populations, but particularly probably in government, around the fact that we've striven for years through technological advances to improve and increase the human lifespan. And wow, haven't we been successful in that? Incredibly successful. And yet, we didn't associate it with the need for more support for that longevity. And it's a bit like Neil spoke about last night around the retail industry when he said that the 4 big supermarkets should have seen what was happening in terms of their competition way in advance of that they did. In other words, they didn't have the foresight. Well, this is more important, as he suggested, but I would also suggest we didn't have the foresight to understand what the implications of long life would be. Now, the world, according to the United States, is VUCA, which is volatile, uncertain, complex, and ambiguous. And certainly our approach to the future of health has had little clarity while we all continue to live longer. And I'm sure, actually, that much of what I've heard today, and I wasn't here yesterday, but there is certainly a great deal of hope in the advances that are now being made, irrespective of the fact that we may say, wouldn't it have been nice if they were made 20 years ago. Nevertheless, you know, as somebody greater than I once said, the best time to plant a tree was 25 years ago. The second best time is today. So today's good. The interesting thing here is that we're all facing exactly the same issue of unplanned admissions or demand and activity, and yet there's no differentiation between the health systems that are run. So free at the point of use for the NHS is not the overriding factor of increasing demand, because we're seeing exactly the same across the US and in other systems where it's not free at the point of use and they're insurance-based. So it's not about the fact the health service is free and therefore for whosoever it is available for all. That is not the issue. The issue is far more demographic and global. So what are the rising demand and new challenges? So what is the issue? The unpredictability or inability to really plan effectively for that sort of capricious demand with dwindling financial resources is placing an enormous burden on the health system, quite obviously, well reported and well known. Many fare better than others, and there will be pockets of excellence in all that we hear about over these 2 days, I'm sure. And in no way am I suggesting that that the improvements are non-existent. Certainly not the case. But few sustained performance over time. We need to find a better way forward than using targets. And I'm delighted to say very recently many of those targets have, if you like, been taken off paper, been taken away from both provider trusts and other providers in the health service, or financial penalties, because they're rather a blunt instrument to change. And in fact, even incentivizing change is in its own way sort of perverse. There should be a need and an understanding for the change that is required in the health service. And that needs to be, I believe, a discussion that needs to be had throughout society. Now, to date, I haven't mentioned the patient. The frail elderly with their complex conditions will increasingly become major service users. They already are, and that will continue. And they are requiring person-centered care and nursing as well as persistent interventions. But the NHS wasn't created in 1948, and it wasn't for that purpose. It was not designed to cope with this type of health issue, or certainly at this level of demand. Now, I daily walk the hospital that I serve, and I daily see the frail elderly, which are the main patients on wards throughout the trust. And it's so apparent that so many of them, despite their complex conditions, would be better elsewhere. And undoubtedly, in a number of cases, should almost certainly never have been admitted in the first place. However, without an option to the A&E and the industrialisation of the modern hospital, and I believe it has been industrialised, where admission seems the prevailing course of action, that is the fate of many of our elderly members of society. And we need to change our thinking as well as our doing. I think we've heard an awful lot about things that are to be done and plans that are in place to provide change for the future. But in lots of ways, a cultural change requires a thinking change. It requires us to think differently. And I think Ashley's earlier talk actually personified that in a way. The public need to be consulted, but more importantly, feel that there's a comprehensive change for the better in terms of health provision. So it's not just, I would suggest, patients we need to put at the centre of our thinking, but it's the whole of society that we need to put at the centre of our thinking. Why? Because, quite frankly, we're all patients. We're either patients in the past, patients in the future, or patients in the present. One way or another, it is likely we will all use our health system. We will all be patients. Therefore, we should all have a say and an understanding of the changes that are required. And we should be concerned. And I say we should be concerned from a financial perspective, because much of this is where the challenge lies. Okay, so what of readmissions? Readmissions are a cost to the NHS, but they are a considerably greater degree of stress to patients. Of that, I'm absolutely sure. For those of us who've been patients, the first and last thing you want to do after going into hospital is to get out. To come back again has to be a failure of some description. The point I wanted to make here is that certainly of that elderly generation, that retired generation is incredibly mobile. More mobile, actually, than probably those that are still working. And therefore, readmissions, particularly for that group, and they are the significant group in terms of hospital activity, often appear well away from the original service provider. And in fact, often not even in the same health locality. And as you can see, that evidence that one 65-year-old gentleman had 72 separate admissions in 50 different trusts. And that was over a period of about 18 months. So one wonders what that particular patient experience was like, one also wonders how well or otherwise he could have been treated if, in fact, information had been available to each one of those. But that's his choice, and that's what the point. We talk about patient choice. Patient choice certainly goes with the mobility of the population, and we need to be aware of that moving forward in terms of our health provision. Now, what I can say is there's little work done on readmissions on its own. In fact, I could find hardly any studies. I could find thousands of studies on admissions, but very few on readmissions. And in fact, when I went back to my own trust, therefore, and said, well, can somebody tell me something about readmissions at Burton? And I was told that neither the trust nor indeed the commissioners were in the least bit interested in readmissions. The only interest that was really had around readmission rates was around individual specialties. And clearly that was from really clinical audit perspective around how well or otherwise a particular specialty was performing. So we don't really know that they bear any relationship directly to admissions, although I do believe they do. There are also, as ever in the health service, anomalies or unintended consequences of work that you might do. So nothing in the NHS we've already ascertained is straightforward, not as it would seem. Now, if this analysis is correct, unplanned admissions should be the principal focus for providers, commissioners, and general practice if we are to get people out of hospital. Now, that seems an odd way of putting it, because what I'm really saying is that the future to people coming out of hospital is indeed not to admit them in the first place. Because actually most of the activity, and certainly in my trust, pretty much all of the focus, the operational focus, is on reducing length of stay. And if this evidence is correct, that actually just by reducing length of stay without actually tackling readmission rates may have the medium-term impact of increasing the length of stay. So the clarity here, if you like, in this anomaly is to deal with unplanned admissions and do so collaboratively. And there is an old adage that what you pay attention to gets done, and hopefully with some further analysis that is what we'll be doing in the future. So there is some agreement around readmissions, but the debate goes on. But there is some agreement around how they can be reduced. And I would suggest if you like, the obvious two are the top two. So improving surgery and focus on readmission rates for different surgeons is really about, as I suggested before, about the performance of particular surgical treatments and indeed their performance. And reducing hospital-associated infections, similarly, will clearly reduce readmissions and indeed are paramount to patient safety. Just in terms of Ashley's point earlier, because as he said, he obviously contracted MRSA and it nearly did for him, so to speak. Certainly at Burton, we've not had an incident of MRSA for 3 years. So I think we're quite proud of that in a sense, but then our target is 0, so as it should be elsewhere in provider trusts. Well, now, all studies I've read, there isn't a case of one silver bullet for reducing admission rates. More the point, studies have concluded there is little evidence to support any theory at all, whether it be telemedicine, care management, self-management, home visits, multidisciplinary approaches, or other interventions which suggest that we may need to do more than one concurrently. Alternatively, we may be looking at the glaringly obvious, which is quite often the case. One piece of obvious evidential research, however, links the number of community beds with lower readmission rates. And what I wonder if there's a similar correlation with admissions. I don't think that piece of work has been done, but it may be fundamental that the number of beds per ratio of patients you have in the community has an impact also on admissions, let alone readmissions. So interventions are as much, if not associated with reducing admissions than readmissions. What's happening elsewhere with the US comparisons are the same as I mentioned before. The US, other health systems, France, Italy, and Australia are all encountering identical issues of unplanned demand for precisely the same reason as here in England and Wales. So the concern in all of that is overwhelmingly the rising costs of healthcare across the world. So it is about affordability. In the US, 1/6 of their economy, of their GDP, is spent on healthcare. In Australia, the costs of healthcare have increased in the last 10 years by 70%. So systems are creaking, not just here, but across the globe, and governments are seeking new solutions to the success of the human race. And whether we like it or not, the issue is definitively cost. And I suspect here and elsewhere, it will be about who should bear that cost in the future. So the US approach to this is really around prevention, has been for many years, both from people like Medicare and Kaiser and elsewhere. It's an insurance-based health system, as you know, and it is desperate for fiscal reasons to find solutions to this unplanned but no longer unexpected demand. They've invested in health plans which are empowering patients with new coverage options that focus on high-performing providers and key tools like care coordination, case management, and particularly those patients with chronic conditions. Now, the chronic care models in the US have proved to reduce admissions for those with chronic conditions like congestive heart disease, asthma, diabetes. And observational studies of high-risk assessment strongly suggest will reduce unplanned admissions, readmissions, and length of stay. And that same type of work is done in the Basque region in Spain, has been incredibly successful. And indeed, actually, there are pockets of excellence here in the UK. Airedale in particular in Yorkshire similarly has the same type of initiative and is reducing admissions for those patients with those same chronic conditions. So you can, although it may work specifically for those particular conditions in patients, there must be something in that actually is transferable to the frail elderly and the more complex. But I think to date that has in some way eluded our thinking. Either way, what is obvious is that the ownership for health, if those studies are correct and those initiatives are correct, that the ownership for health is rightly moving back towards the patient as opposed to in the hands of a provider or a particular organisation. So my contention is that patient readmissions, so I have addressed the question, are a byproduct of the first admission and not on their own an issue. And improving the shared use, there should be use of patient data and information, and developing a more consistent approach to patients, including common language and communication, the cultural aspect, is key to that. Given all of the informed debate and analysis of unplanned admissions, I have seen little discussed about how the part and the power of information can have on the change and improvements that are needed, other than this morning and indeed yesterday, and I'm sure that will continue through this afternoon. Neither do I hear a lot about the human side of this issue, how we successfully engage with our patients, with the population as a whole, to bring about change in our system. So, looking to a conclusion, if you like, around those two aspects, sharing what we know. I was delighted to hear from Paul this morning. I was unaware of the work planned in terms of the care plan for the future. Although it's only just starting, it clearly addresses many of my observations here around moving forward in terms of change. What I do know is that currently, data is primarily used for contracting, for transactional reasons across the health economy. It's raw data. And in fact, in my own health economy, which is why I can't suggest that Burton is a paragon of virtue and success in terms of collaboration with community, our local health commissioners, our own commissioning group, actually use our data, raw data, to reflect back for contractual reasons that we should both try and achieve and indeed get paid for. So they're very much used for a transaction between the two organisations. They are not used in any way to deliver intelligence or indeed information. So transform raw data into meaningful and useful information to enable a revolution in how we do business is certainly the way forward, and I'm delighted that that would seem to be the case, even though it may be some way off. Again, there are pockets, I think, of excellence here. Again, I mentioned Airedale, where I think they're introducing a shared IT platform across primary, secondary and social care. And they use it to support their collaborative care teams across the whole of that region to deal, if you wish, particularly with the frail elderly with complex conditions, to keep them out of hospital wherever that can be achieved. But currently, the relationship between providers is primarily transactional and reactive, and the data follows that type of interface and relationship. So it's time to build, store, access, and share national medical and non-medical information, which is linked to a single patient identification, so that patients and the NHS can co-design pathways fit for each individual. So you can do assessments in the community to keep people out of hospital, not to refer them to hospital, a key change in the way that general practitioners and diagnosis works. And the ambulance services can improve significantly on rapid access to, or not to bring rapid access to the nearest acute hospital in a circumstance, but to actually deal with the issue in the patient's home or indeed in their current community setting. It's interesting, I was speaking to a colleague of mine at Burton who joined the health service 13 years ago, specifically to implement the national spine for a universal choose and book. We know 13 years on, we don't have a universal choose and book, and indeed, we still don't have a national spine. So again, that adage of, when is the best time to plant a tree? Well, it almost certainly was 13 years ago. But today's good enough, as I say again. So if we can build on the momentum that has been discussed over these 2 days, and certainly the work that is planned, then it would seem that we may indeed be able to revolutionise the change that is needed. It's very interesting. I was sort of debating myself around our NHS number, or in fact how important that was in terms of a unique identifier. We can probably, many of us can probably just immediately spin off what your registration number of your car is, or you'll certainly be able to tell us what your PIN number is for, if you would, no, probably not a good idea, but you know what your PIN number is for the numerous cards that you hold in your wallets or your purses. In fact, you don't even need to know your bank account number anymore, do you? You can just do it online. It's unnecessary to know it. And then very recently, of course, we don't any longer need a tax disk because that's going to be completely invisible because the data is available elsewhere for those that need it. And indeed, very recently, you don't, for those of us who've got a paper license, I'm old enough to have one still, but yeah, there we go. You don't need those anymore either because actually that data is just accessible and available. Isn't it strange that we do it for things that actually accommodate our life so easily, if you like, but actually when compared with our health, they're actually, pretty minor issues, are they not? And yet we've not paid the same attention to that type of information, that type of uniqueness, that type of ownership for our own data and who should access it. And I think there's a reason for that, and it's really my final point. And in lots of ways, this epitomizes that final point, which is the reason we don't actually own it is because in some way other people have done so for us. The one thing that I observed when, if you like, coming into the health service particularly and watching patients' journey through, and being a patient through from my general practice into a provider trust. I haven't yet gone on to the care home yet, but doubtless that will come, is that actually the language changes and the relationship changes. So you go to your GP, it's very business-like. Indeed, it is a business, is it not? And it's rather uncertain, it's rather unconditional. You go in and you have a consultation. It's a very business-like discussion in lots of ways. Could be friendly, but, doesn't have to be. And what you usually get in terms of the first response from your GP is, what can I do for you? And what you can do, what you really say, so what you're asking is, well, actually you can tell me, can you tell me what's wrong with me because I've got a bit of discomfort or whatever it may be. Quite often that ends up with to a referral or a prescription, and I moved on down you moved on down the line. It's part of a supply chain. As you come out, if in fact there is a referral, you start to lose a little bit of choice. You start to lose a little bit of independence, do you not? Just a tad, even if you're strong, you start to lose something. You move to a hospital. Now, the hospital is like a machine. It's a functioning system. It's a production line in lots of ways. And the talk is completely different when you walk into a hospital. They talk about episodes. They talk about slots. They talk about you having an event, which actually is strange terminology indeed. But more importantly, what they say to you is, what can you do for me? There is a complete change of relationship in that you become a child and they become the adult. And more importantly, and most importantly, the first thing you do when you go into hospital, particularly if you go in through the front door, is they take you off your legs and they put you on a bed. You are immediately dependent. You are no longer independent. You're dependent upon other people, all of whom deliver, I'm sure, great care and are very compassionate. Nevertheless, your independence is becoming lost. And then you move to a community or social care, and the pace changes again, and the language changes again. It's about services, about time allocations. It's about medications, therapy. It's about access. And now they want you to get up and be mobile. And what you therefore get in terms of language is a completely change again, which is about you should do this. It's about encouragement. So I guess what I'm trying to say is that in lots of ways, the process of delivering care actually makes us dependent on others and indeed takes away the ownership, not just for the data and for our own information, not just medical, but other information, and moves it somewhere else to other people who know better. And I strongly suggest that has to change if, in fact, we're going to implement the changes we need in health. I should say that 20% of those people who we make dependent on the system, never recover. And that in itself is, I would strongly suggest, a good reason for change. So thank you for the opportunity and thank you for listening.